Thank you very much, James, for giving a really personal account of your journey, which I think is incredibly important. Chris, shall we share questions for the panel? Start with a few and then go on to the Q&A session. So I think this has been a great session, and I think emphasises the importance of health economics and also at the end the patient input into the journey of OA. I might start off with maybe a question. Might address this to our first speaker, Zanfina. As a surgeon and a researcher, I'll probably take a little bit of issue with saying total knee replacement is the usual care for it's the usual care for failed conservative treatment. And I think I need to emphasise that. So one of the questions that I think Opus and other people are researching on is how do we actually get a number of people who've had adequate treatment of osteoarthritis, and that defines the population that may progress to OA. Are those numbers available? And if not, how do we go about assessing those people who've had adequate care for primary knee OA?
I don't know. You tell me.
Good. I was hoping you could answer that question because I don't know.
I think it's quite a thanks, Richard. Great question. I think this is a problem. I know you're saying that people would have had adequate physiotherapy and then would have gone directly into having a total knee replacement, but I don't think this is the case in Australia. Mm-hmm. So obviously those patients have to go for at least a number of sessions, not only just 5 sessions, to see if it's working or not. And my study, it sort of opens a discussion that we have to sort of discuss that a surgery, it's not alternative for all. And in this case of the study and also the GLAD project, we've seen that those have had surgery plus non-surgical management, but the delay on having surgery was quite large. And also people probably, Christian is here, might like to comment a little bit more about GLAD as well. GLAD itself, if it was about to implement it in Australia, and currently we've costed, I don't think it will cost more than 1,000. So those patients who need to go under a guideline physiotherapy and diet, that would be a great options to start with rather than immediately going and having surgery. This is not the answer for all the patients, but I'm not answering your question, how do we get more patients, information about primary care? I don't know this answer. Maybe Chris knows.
Well, one of the things we're trying to do, and we've just had some success recently in Opus, is to link the SMART registry with MBS and PBS records, so that we can look at someone who's had a joint replacement and then look back in their prior history and see if they have accessed chronic disease management plans, if they have accessed those 5 free physio sessions or not, so that we can try and see, well, on that pathway to end up, hopefully at the end stage, has that patient actually had some management beforehand? And what we're seeing in our initial analysis is that it's certainly not always the case, and in fact, it's not even regularly the case.
And the last speaker actually pointed out that those sessions are so minimal, so barely the impact that you would get with those 5 sessions, it's minimal. So I think we have to open the discussion, and I totally agree. And Richard mentioned that we have to engage consumers when we make decisions about what value care should be implemented in our healthcare system, rather than just sort of make decisions without including consumers into a decision-making process.
I think this is really important. As a senior author on the paper that Jason mentioned, the projected increase in knee and hip replacements in Australia, we've got some good and bad news. Because this was a projected paper, we're in the strong position to actually look at the new data. So we're just looking at the data at the moment, and the good news is this model is robust. The bad news is the projections have actually gone the way we said it is. So there is an increased use of knee replacement particularly. So I think this is a really important area we can try and reduce Jason, I'll ask you, because you're studying this, what do you think would be the biggest single area where we can actually reduce the need for knee replacement surgery? If you had to tackle the amount, you were given the portfolio by Greg Hunt, who's got some COVID dollars left over, says, righto, Jason, you're a PhD. What would you do? And advise me.
That's a very good question. I think it's challenging for a lot of reasons because there's so many pathways patients end up getting surgery. But I think, to be honest, the best way that I can see in reducing the need for surgery is really ensuring that the surgery we're performing is appropriate. So patient selection and identifying the best ways of seeing which patients truly need and benefit from surgery, and not so much preventing, but identifying patients who might not necessarily need surgery or whose expectations of surgery differ from what surgery can actually offer, and preventing that curve of patients who go through and end up getting surgery and end up being unhappy with the procedure or not getting the expected benefit, and then end up being in the healthcare system over the longer term, requiring ongoing treatments, managing complications and managing ongoing pain. And I think that's probably the key area that I would focus on in terms of identifying appropriate pathways, optimizing the non-operative management, especially when the current state of play seems like we're not really doing that as well as we can, especially with all the evidence that's available. And what we'll end up with, in theory, is essentially a group of patients who get surgery who would probably be more likely to benefit from surgery, and then we can start looking at better ways of sort of optimizing the surgical cohort who actually do need and will benefit from surgery. But that's just my 2 cents.
Kevin, I'd like to bring you into this. One of my experience over many years of clinical practice is sometimes patients want a quick fix. How would you, as a patient that's gone through there and you've had knee arthritis, how would you address that quick fix of surgery which some patients want and are probably incorrectly sometimes given, or more often given perhaps by surgeons? What would you like to say about that?
To be clear, I'm probably not in a position where I'm looking at getting a knee replacement or hip replacement. Mine's a lower back condition, and unless I'm mistaken as a patient, it's very difficult to replace facet joints, if not impossible. But yeah, quick fix. I think a lot of patients, when we enter the system initially, knowledge is power, as I said, and of course everyone wants a quick fix, and there's that always something on the horizon. There's got to be hope, and a lot of people take that hope and they go, yes, this will be it. But often it's a long journey, and we have that crossover from acute pain into chronic pain. So I think there's 2 discussions happening here, whether we're talking about acute fixes or is there a fix for chronic long-term pain? Perhaps not. We just have to manage it. So all I can say is be your best advocate. And I'm the one, for me, who advocates for myself and nobody else. I think they call it pain management stewardship. I was at a Brisbane event last week where that was the big buzzword. So that's perhaps the best way I can answer that. I like conservative treatment. I don't want surgery. I'm happy being conservative for now.
Yeah, I think you've just nailed it. Be your own advocate, be most informed. And I think that's incredibly important. Now, we have quite a lot of questions coming through. I'm conscious of the time. Chris, would you like to perhaps take some questions from Q&A?
Sure. One that we've got in here is does end stage OA obligate joint replacement? Is physio, pointless at that point? And maybe that's one for Jason and for you also, Richard.
Well, I'll say quickly that physio is never pointless, and end stage OA is not if it's a radiographic disease, it's only end stage if it's a combination of everything. End stage radiographs, end stage patient treatment, end stage fed up, bad problems, everything. That's what end stage is. I think sometimes we get distracted by radiographic diagnosis, and I've certainly seen that with primary care referrals. That's irrelevant. It's relevant if you're going to do a joint replacement. You must have end stage radiographic disease, but it's completely irrelevant to the process of needing a joint replacement, I believe, if you just present with an X-ray. Jason?
The only thing I'd really add to that is the use of the term obligate. I don't think it's one of those decisions that really is an obligation. It ultimately comes down to a decision that's shared between the patient and the surgeon, discussing sort of what the symptoms are, what the disability is, and what the expectations of surgery are. So it's not really, so patient comes with end stage OA and therefore that obligates an operation. It's really a shared decision based on all the information and data we have available, and it's an informed choice that the patient makes in consultation with the surgeon. So.
Great. Zanfina, I have a question for you regarding the GLAD work that you've done. And you've taken the savings that were seen and essentially extrapolated them out across the Australian population, if I've understood that correctly.
Correct, yeah.
How confident are you in that generalization? Are they the same cohorts, or are where you've seen the benefits in the GLAD program, are they a slightly different cohort to the cohort of people that we see getting joint replacement across Australia?
I think obviously we are not going to sort of include the people with severe OA. We are talking about sort of a management pre, but to your question, yes, we have extrapolated, and the data that were extrapolated, obviously the efficacy data were taken from a randomized clinical trial. And we have received funding from government to do sort of a similar study in Australia, and hopefully we will see this effect soon. And as Christian pointed out, looking at the MBS usage, it's not likely to tell us if it's appropriate care being delivered or not. So basically, I must say that we actually have to wait until and see whether the GLAD will produce the same results. But the projections that I've done, I'm confident on that, and we've used a number of scenario analysis, and we've shown that even only 8% will be managing to go and do the non-surgical management. The program will be cost saving, even if it's costed at 30,000. The surgery cost is quite high, and that's why you would receive those differences. But I think we have to open a discussion. It's not about this study. We have to open the discussion in Australia about having physiotherapy as a first line, not in all cases, not for all patients, not only 5 sessions, but it has to be a more organized program that will give patients a choice whether they should do a physiotherapy or go directly and have a total knee replacement.
And I'll follow that one up and for the whole panel as well before a specific question for you, Kevin. But what we find, and I think, Kevin, you highlighted it, that actually your GP didn't even make you aware of or potentially wasn't aware of the 5 sessions that could be had. And what we see in the data often is actually there isn't this big lot of patients getting to 5 sessions and then disappearing. So what are the other barriers that we seem to be seeing as to why the system's not working appropriately? I think just that we're not funding enough is only one part of it.
Yes, agree. So funding one enough, but also we have to hear patients or consumers' voices. And I don't think we engage consumers enough.
Yep, look, I think that's right. I'll quickly throw to you, Kevin, before throwing back to you, Richard. There's a question from Anne Smith around your presentation and just around those fantastic lists of proactive strategies that you've listed for management of your pain. Can you give us your perspective about how important those techniques have been for you?
Yes, thank you for the opportunity. And I actually pushed the wrong button. I was going to write my answer as a text. But to answer Anne's question, yes, it's very important, but it's extremely difficult when a patient, from my perspective as a new patient to this pain 12 years ago, there's a common misperception or a common phrase that people often say, which is the pain's all in your head. And a lot of patients don't like to hear that. But if we unpack that, yes, it's extremely important. And for me, I've got to practice my gratitude, practice my acceptance, practice my meditation, do something for me, take time out every single day, because if I don't, you get back into old habits. So it's a case of having a framework and just following a regular routine every day, and it becomes second nature. I have to do it. I can do it now, but it's very difficult to explain to patients as they enter the pain journey. Knowledge is power. Thank you.
We can see some of Christian's made several comments on the chat room, which is very important. And the top one, I'd certainly agree. the balance of spending is inappropriate in terms of management of OA. But it's greater than that, because you'd all well know the balance for funding for research into OA is inversely proportional to the numbers of people that are actually affected by the disease. And that's something that we perhaps have to address as a research group. And I think, Chris, like all things in politics, economics and money counts more than patient health. And I say that without being kind of mean, but I think that's probably the reality. How do you think your work can address the economics and so that it's economic really important to address these issues rather than it's good for patients, which is where we as clinicians often come from?
And rightly so. You know, I completely understand as clinicians that your role is to optimize patient outcomes. And so where I think that health economics really fits nicely is that it does provide that that second lens to cost, and what we really need to do as a profession and as a team within Opus then is use that to influence decision makers. And I know, Christian, I've been looking at your chats and your questions. Personally, I think there's kind of two lots of decision makers, and I think for osteoarthritis, private health insurers are a big decision maker. They spend a whole lot of money on their clients. And so finding ways to influence and work with them, I think, is really important. And I know you've said you've had some struggles there, but are continuing to do so. What I've found in my work with them is that they do have a strong cost-effective lens. And so when we are able to do studies like Zenfina's done, I think that is really powerful. And Zenfina, I am interested to hear if you feel that your work has actually been able to make a difference. And if not, what are the next steps that you want to take?
This has been just sort of published recently, so we don't know as yet, but hopefully.
Yep.
Richard, did you wanted to say something?
Well, no, I've actually got an interesting comment that maybe we could discuss and the people online. We've got a natural experiment that will now go on in the UK. I've just been speaking with a lot of my UK colleagues in NHS and reviewing some articles, and they've had a 50% reduction in the level of joint replacement as a result of COVID. The estimated time to catch up without taking into account any population increase or any increased need for service is a minimum of 10 years to catch up on the people who've already lost out on joint replacements. And I think, so we'll be following what happens as a natural experiment in the UK, mainly because it's within the public NHS system, which a lot of us have worked in. And we would hope to see that potentially a number of those patients, and I'd say probably more with knee arthroplasty than hips, may not need surgery and may have got by without the surgery. But it's very difficult to know how that will pan out, because it also meant COVID restricted the access to all the other surfaces that are needed to treat patients with symptomatic OA. So, but certainly surgery is the end stage. There's going to be an interesting follow-up now for the UK.
Indeed, and I'm sure we'll have the same experiment here to see, perhaps not to that 10-year period. One of the things I always come back to, though, is that on average, you know, it's been shown, and Jason highlighted it, that joint replacement is such a cost-effective surgery. And so in and of themselves, seeing projections that you've published on, Richard, that are increasing, you know, in and of itself, that isn't a bad thing. As long as that cost effectiveness, as long as that quality of life for the dollar that you're investing is still appropriate. And I think that comes back to that. How do we get you know, ensure that selection's right? How do we stop getting that 1 in 10, 1 in 5 wrong? And so, Jason, I think maybe a nice question to you is just around the tools that can be used at the clinician level. So the nomograms and the decision tools. As a surgeon, as someone who's thinking about that selection process, how do you find those tools? Do you find them more valuable than, say, a generic guideline, because they're able to be a little bit more personal to the patient that you're seeing? And Richard, I'd ask for your insight into that as well.
I'll provide a disclaimer that I'm not a surgeon.
Yet.
And I think this question will probably direct to Professor De Steiger, a bit more than appropriate.
Yeah, well, he will be, so it's okay. I think it's a very good question. Patients are individuals, and pain is subjective. So I've used for many years, developed a MAP score for waiting list many years ago at the Royal Melbourne. I was involved in the original Oxford questionnaire in Oxford back in the early 90s and have used that for over 20, 25 years now. And just out of interest, people might be nice to know that I've just looked at my 20-year Oxford follow-ups, and my Oxford mean score pre-op has not changed 1 iota from my current mean score for pre-op. So I'm quite a conservative surgeon. I hope to remain that way. Look, it's the personality of the patient, the personality of the injury, what they want, what they need to achieve. I think there's a huge amount of research that needs to be going into this. Obviously, Opus is looking at this within the PROMs. We haven't had a chance to touch on PROMs, but it's an incredibly important field. And with the national PROMs rollout with the registry, some of the things we're seeing are incredibly interesting. Expectations of surgery. You can have a near perfect disease-specific score, a very good EQ, quality of life, satisfied, but the operation didn't meet your expectation. And that's some very interesting data that we'll be presenting this year. So maybe some expectation change may help how people get over surgery. But look, yeah, I'm really reasonably conservative. I think you need to end stage arthritis for a joint replacement is exactly what it is. When you only offer it to people who've been through all the proven treatments. And I'd perhaps like to throw open the panel. We haven't discussed it, but the amount spent on complementary unproven medicines is probably greater, I understand, than clinically effective treatments. And I guess, where do we go in advising government about these? Any suggestions from anyone? I don't know.
Yeah, it's a big problem on complementary medicine, Richard, and a lot of other sort of, I'm not talking about physiotherapy, but I'm talking about other ways that patients get engaged and told to use complementary medicine. And there is no evidence to support that for decision making. I just wanted to check one of the Christian questions. Did we respond it? I think to the whole panel. Question on billions of public health and private dollars on surgery every year, and just a fraction amount is spent on first-line care.
I tried to address that very briefly by saying it's not just OA care. That's the amount spent on OA is a very small proportion of the amount spent on other treatment options that are perhaps sexier than OA. I don't think the proportion was appropriate. I'm sure probably no one here thinks it is appropriate. But how we go about changing that is, I think, the question that we all need to address as researchers and particularly perhaps policy advisors.
Yeah, but I guess with regards to GLAD, now we know that GLAD doesn't cost that much if it's implemented in a country. We know that is effective, but we know only for a short period of time. Now we need to sort of, and I know that GLAD Australia will start soon. We have been delayed because of the COVID and we haven't started recruiting patients, but soon this will start. But we need a model to show that, as I said, those delayed people that were not having surgery, does that actually happening, or we are just shifting to the longer years of them not having surgery? So the whole idea is to sort of have more information to make a proper decision making that in this group of population that we're studying, is it surgery the first desired one, or we should go with the physiotherapy first and then, yeah, the last source.
And look, I think you're spot on, and it's exactly why I tried to highlight those couple of policy models that have been developed internationally, because they do take a lifetime approach. And as soon as you can put all of those building blocks in place, then you can do proper policy analysis that highlights, hey, a little bit more funding on primary care or alternative options earlier on can actually save money down the track. And so I think that's probably a good spot to leave it. Sid, I see you've jumped back on, but I want to thank everyone for their wonderful presentations, and for Richard for leading us so well. So I'll throw back to Sid.
Thanks again, Richard, and thanks again, Chris, for that very important discussion around health economics. We have come to our lunch break for the time